All right, renal disorders, chapter 17. So again, the disclosure statement. I don't own this material under fair use. I'm providing lecture content only for my nursing students using this material. All content within is only for educational purposes for nursing students and does not provide medical advice. So in this chapter, we're going to go over renal disorders, the lab findings, selected renal disorders based on clinical presentation. All right, so let's go back to basics. Anatomy and physiology in your book on 401. 2 kidneys in the retroperitoneal space next to the vertebra, right? The vertebrae, slightly above the belly button. So the renal arteries supply that kidney with blood flow. The right kidney is slightly lower than the left kidney. And each kidney contains 1 million nephrons. The nephrons contain the glomerulus, the tubercle, and the collecting duct. Nephrons filter harmful products from the blood. Each renal pelvis extends to form a ureter, and each ureter drains into the urinary bladder. The urinary bladder collects the urine and is excreted via the urethra. The normal urethra has a one-way valve, allowing drainage and prevention of retrograde reflux of urine. Renal function is not completely mature until about 2 years of age. It can take up to 3. So, when you're doing an assessment of someone who comes in with a renal disorder, you're talking to them again about their symptoms, alleviating factors, what makes it better, what makes it worse, what happened in the past, preceding illnesses, their medical history, any hospitalizations about this, the use of indwelling catheters, if that might have been an issue, if they had just been in the hospital for surgery and had a Foley catheter, there's a good chance that there's an infection because of the catheter being used. So you just want to ask them, had they been recently catheterized? And then current medication use. So you're looking for nephrotoxic drugs such as aminoglycosides, amphotericin B, vancomycin, NSAIDs, heavy metals, and ACE inhibitors. And you're talking to them about a history of fractures. Osteoporosis is a common finding in chronic renal disease. A history of growth restriction, a history of urological anomalies, and previous surgeries and sexual activity. STDs have sexual activity as a risk factor. So your fluid needs per kilogram for a 24-hour period, weight 0 to 10 needs 100 cc's per kilogram. 11 to 20 kilograms need 50 milliliters per kilogram, and over 20 needs 20 milliliters per kilogram. So family history that might be relevant: UTIs, chronic kidney disease, renal anomalies, deafness, because the kidneys and the ears are related. They are formed in utero at the same time. Immune disorders, thyroid disorders, gout, anybody in the family needing dialysis, and anyone with growth restriction. That needs to be well assessed on any patient that comes in with any urinary issues. So a dietary history, preferably like the protein intake, could be the worst problem for them. So you really want to know, like, how much protein are they getting a day? Because if they really overdo their protein, that could be killing their kidneys. So the keto diet isn't for everybody. So the more protein they are taking in, especially males, the more at risk for gout they'll have, because protein is broken down into uric acid. Protein intake, fluid intake. Obviously, a poor fluid intake would mean dehydration, which could lead to renal failure. Their calories per kilogram per day, their special dietary needs. Again, ketogenic diet increases the risk of nephrolithiasis. So that's why we're asking these questions. High oxalate foods increase the risk. Failure to thrive, we're asking about that as well because many renal disorders actually come from the renal system in utero and growth patterns. All right. So once you get that done, kidney function, blood pressure, things like that that you're doing, bounding pulses would tell you there's way too much fluid. And then in the gastrointestinal system, chronic kidney disease is associated with anorexia, constipation, and failure to thrive. And then your genital urinary system. We're asking about circumcision and things like that as well. Urine color. Frothy urine could be proteinuria. Their urine color. So red urine could be from food dyes, blood, other things. Tea-colored, cola-colored, or red, hematuria, blood in the urine, that would be a key indicator of a problem. And then INO, obviously, counting number of diapers or number of pees and poops per day, keeping a good record. So maybe we tell them to keep a record of the last 3 days before coming to the doctor's office. That would be helpful. And then selected values that you're looking for, your urinalysis, your serum electrolytes, and your CBC. All of the normals are on page 403. So based on the Holiday-Seeger method, 100 mils of fluid are needed for every 100 calories metabolized. Dermatologically, you might see rashes, purpura, sticky, dry mucal membranes, which would indicate dehydration. Neurologically, you might see hearing loss, hearing acute problems, physical ear abnormalities. The auditory and renal systems occur at the same time in fetal development. And pain is always pathological until proven otherwise. In the musculoskeletal system, you're just looking for linear growth patterns, muscle cramping, bone pain, fractures, because osteopenia is secondary to hypokalemia because the inability of the kidneys to convert vitamin D into an active form. Gastrovertebral tenderness associated with UTIs in older children. And then lymphatic system, you're looking for preorbital edema, facial edema, ascites, and scrotal edema. Sacral edema, dependent edema. The endocrine system, you're looking for a thyroid disorder. And the renal system, you're looking for large kidneys that are felt on exam, and urine output. Normal urine output in children is 2 cc's per kilogram per hour, and 0.5 to 1 milliliter per kilogram per hour is acceptable in teenagers. So some of the disorders of the urinary system. So think UTI, which is most commonly caused by E. coli because the holes are so close, and that's usually between 2 and 6 years old. A UTI, unfortunately, can become septic quite frequently, quite fast. So that's in your book as well. Remember, like neurogenic bladder could also be an issue with spina bifida kids. So your diagnostic tests that you're looking for is your urine sample, and then contamination is in your book as well. The nephrolithiasis, renal caliculi, it's in the book. Let me just try to find this. Urine stones. There we go. Kidney stones, urine crystals, and that steadily has risen in children and adolescents with the increasing number of obese kids, metabolic diseases, vitamin D, calcium, vitamin C, diuretics, steroids, and some anti-seizure drugs. Metabolic disease, genetic or urinary tract abnormalities are going to have more recurrent kidney stones. And female are at a greater risk than boys. So kidney stones in pediatric patients tends to sound like abdominal, flank, and back pain, hematuria, UTI, poor feeding, renal failure, nausea, vomiting. And we, again, first thing would be urinalysis, and then abdominal radiograph, ultrasound, CT scan, laboratory analysis, or a 24-hour urine. So remember your 24-hour urine sample. You need to go back to Skills 3.0 and do a urine sample in the Skills 3.0. That will help you figure out. They could ask you 5 steps in collecting that. They could also ask you what to do if the nurse tells you that she accidentally threw it away. So it's important to put the sign on the door that you're in the middle of a 24-hour collection so that nobody throws it away. It needs to be on ice, right? So adequate fluid intake, if not, IV fluids. Pain control, could use morphine, Oxycontin, acetaminophen. You're training them how to do urinary output recording. We could do some lithotripsy if we had to, just monitoring for renal failure. So imagine if you only had one kidney, that would be a concern. Acute in the hospital, you're just dealing with the IV intake, stone collection, straining all urine, and then prepare them for possible shockwave lithotripsy, which is shock waves to the back to break down the stones. So again, make sure that you understand this. Education, education, education. Nutrients, nutrition requirements, big time. Potassium citrate has some part in preventing kidney stones. If you have your child take a daily dose of potassium citrate, it could decrease the occurrence. And then again, low oxalate diet. So oxalates are found in plant food that can increase stone formation. So furosemide, butamide, spironolactone, all those drugs, know that. Avoid high protein intake. Avoid fast foods, artificially flavored and sweetened drinks. And then on to nephrotic syndrome. Nephrotic syndrome is the most common kidney disease in kids. And that's massive proteinuria, hypoalbuminemia, anemia, edema, hyperlipidemia of unknown origin. The loss of protein in the urine changes the pressure of the system, so it can cause extracellular edema. This is between 2 and 5, and nephrotic syndrome are minimal changes, mostly in the glomerular area. Nephrotic symptom often occurs after an upper respiratory tract infection. So just so that you know that. Fluid leaks out of the cells. So edema is gravity dependent, causing orthostatic hypotension, thromboemboli, malnutrition. Those are all going to complicate it further. Antibiotic use for nephrotic syndrome should be initiated when an infection is suspected, and antibiotics can be tailored based on the culture. So always do a urine culture, UA-CNS. Clinically, these guys present with edema, weight gain, decreased urine output, anorexia, they're easily fatigued, and hypertension. So for these kids, the goal is oxygen delivery for respiratory distress, CT to find out if there's a pulmonary emboli, ultrasound Doppler, drainage of pleural effusion, IV fluid boluses, diuretics, and antibiotics. Our goal is to prevent thrombus formation. So they may be on corticosteroid therapy, diuretic therapy, albumin infusions, and a nutrition consult needs to be done. Strict daily weight at the same time every day on the scale, unclothed. Strict monitoring of I&O, abdominal girth, again, monitoring vital signs. Encourage ambulation. You don't want them to get a blood clot. And understand values of the family and their cultural practice. So we're basically treating it as a pulmonary emboli until otherwise told that it's not, because it's going to sound just like that. Again, vaccine safety. You would never give vaccines when a child's receiving high doses of steroids or cytotoxic agents, cancer-causing agents. All right, so a quick test. Urine nitrates are usually not, almost always, or never diagnostic of a UTI. Can you count on your nitrates? Almost always. If there are nitrates, you know you have a UTI. Okay, moving on to post-infectious glomerulonephritis. That's an inflammation of the glomeruli in response to a preceding illness, such as a streptococcal upper respiratory or skin infection. And it's usually apparent 10 to 14 days after the acute infection. This affects early school-age children, 95% who recover completely. And the peak ages are 3 to 12. So the most common studied form of post-streptococcal, 6% have sustained hypertension. So again, if your kidneys are not working well, your blood pressure is not going to work as well either. So in your book on 413, you can see the painless hematuria, tea-colored, cola-colored, or bright red, proteinuria, oliguria, hypertension, edema, anorexia, as in not wanting to eat or not being hungry, upper respiratory or skin infection, pulmonary edema, abdominal pain, malaise. So you're doing serum urea and creatinine, it's going to be elevated. The serum protein is going to be decreased. WBC is elevated. Sed rate elevated, because it's an inflammatory process. Anemia, hyperkalemia, throat culture positive for strep. So hemodialysis if we're in renal failure, antihypertensive medication like nifedipine. If they're hyperkalemic, we're going to give them Kxalate or sodium polystyrene sulfate. And you're doing seizure control, lorazepam. Again, antibiotics when you have the UA-CNS back. Nutrition consult for no added salt, fluid requirements. Cerebral complications, so you're assessing the neurostatus constantly. Renal replacement therapy if needed, potentially. And then educating the patient on the high blood pressure, the seizure precautions, and the hyperkalemia. Seizure precautions means bed rails padded, right? Everything ready in case of a seizure. All right, and then on to HSP. So this one is self-limiting. It's a multi-system vascular disorder of children. It has usually like a tetrad of symptoms like rash, not being able to move, their legs very well, abdominal pain, hematuria. It's self-limiting. Most kids have full recovery. Follows an upper respiratory and tract infection, and it's usually most common between 2 and 6. Intersusception might occur, and that usually comes from the intestinal edema and hemorrhage. So what's it going to sound like? A colicky abdomen pain, palpable purpura, non-migratory arthritis or not being able to move or stiff joints, edema of the face, lips, hands, feet, scrotum, gastrointestinal bleeding, hematuria, proteinuria, anorexia, malaise, and red or purple subcutaneous nodules found in the pretibular area. So CBC, erythrocyte, sed rate, going to be elevated. C-reactive protein going to be elevated. Coag studies will be fine. Urinalysis, proteinuria, and hematuria. A positive blood stool, and your IgA. So this is, if the intersusception's there, take them to the OR. If renal failure, it's going to be hemodialysis. You should prepare the patient for a hemodialysis catheter being used. Evaluate family support, and then get consent. So IV fluid hydration, fluid restriction for insensible losses, restriction for vital signs. It has to be strict monitoring, especially the blood pressure. Daily weights, avoid NSAIDs. Glucosteroids. Only use narcotics if severe pain, otherwise use other pain controls like positioning, distraction, and therapeutic play. Skin care for breakdown, edema, and rash. Watch for abdominal pain, occult blood stool, currant red jelly stools, antihypertensives, daily weights, INO. So they might go home with chemistry strips. So this one's big on education. Home blood pressure monitoring, importance of follow-up, when to seek care. The next one's hemolytic uremic syndrome, HUS. So HUS sounds like hematochezia, which is bloody diarrhea, pallor, oliguria, hypertension, seizures. Again, seizures, not good. Thrombocytopenia, not good. And it's the most significant complication by E. coli. So prepare the patient for hemodialysis, blood transfusions, seizure control, IV fluid hydration, I-N-O, packed red blood cells. So imagine this test question with a Jehovah's Witness. They won't accept those packed red blood cells. Edema, mental status changes. Avoid NSAIDs. Provide analgesics like oxycodone and morphine. Antihypertensives, your enalapril or your nifedipine. Strict monitoring, daily weights, the whole deal. And you're doing fluid and electrolyte status big time. High calorie, high carb, no added salt, no potassium. Enteral feeding, if needed. Peritoneal or hemodialysis catheter. So edema and perfusion, big time. So educating patient and family, dietary restrictions, appropriate skin care, especially with parents because they want to, treat their kid. What they're bringing might actually be hurting them more than helping us. So lots of education on what they can and cannot eat. Acute kidney injury, previously known as acute renal failure. This is poor renal perfusion or injury and volume depletion. So this is decreased renal function, lead to the ability of the kidneys to clear the blood of urea and regulate fluid and electrolyte imbalances. So poor perfusion, such as ischemia, toxicity, retinopathy, nephropathy, or sepsis. So volume depletion. The prognosis is based on the causative factor. So if the kid over medicated themselves, like an ibuprofen overdose, this is where this comes from. So you're looking for a history of fluid loss, drug overdose, oliguria, hypertension, edema, seizures, anemia. You're looking at the BUN, creatinine, electrolytes. Anemia is going to show up on the CBC. Renal ultrasounds are going to be large or normal on the kidneys. And then possible arrhythmias from the electrolyte imbalance. So fluid resuscitation with NS. Dump fluid on them. Fluid removal by hemodialysis. Seizure control. Seizures in renal, right? You hear me saying seizure disorder, seizure disorder, seizure disorder. We have to look up the electrolytes because it could be hyponatremia, hypoglycemia, and hypocalcemia. Because seizure activity can be from hypertensive encephalopathy as well. So again, education, home dialysis, home blood pressure monitoring, avoid high protein diet, avoid medications with phosphates, low phosphorus, low potassium, appropriate diet restrictions, fluid restrictions. This patient is a acute kidney injury. Could be chronic renal in the end. So chronic kidney disease is stage 1 through 5. So you can see that in your book on 419. So stage 1 to 5, 5 is end stage renal disease, the worst. So that's only 15% on dialysis. So these kids are going to be born with congenital anomalies of the kidneys or the urinary tract. Hypertension is going to be the biggest complication. Black children have a higher prevalence than any other child in the US. And renal replacement therapy, peritoneal dialysis first. Both hemodialysis and peritoneal dialysis is going to require extensive training. So the parents will have a lot of training before they can do this at home. So clinical presentation, hypertension, poor weight growth, abdominal pain, edema, seizure, nausea, vomiting, pruritus, dyspnea, just like an adult. EKG for your dysrhythmias, BUN, creatinine, electrolyte, CBC is going to show anemia. So IV infusion of isotonic fluids, and then fluid removal through hemodialysis. Seizure control, blood pressure control, hyperkalemia prevention. So again, low protein, low potassium, low phosphate diet, appropriate fluid restrictions. Know how to do peritoneal dialysis. So peritoneal dialysis, different from hemodialysis. Peritoneal dialysis they could do after school and still go to school during the day. So it's using the peritoneal cavity instead of their arm. Vaccines, they're routinely administered to healthy children. Influenza is recommended, pneumococcal, but live viral vaccines are to be avoided. And then we've got genitourinary. So cryptorchism, we already talked about this. Hypospadias, we already talked about this. Cryptorchism is one testes that's not descended. 1% of boys at 1 year old will still have cryptorchism. So most of the time, it will come down. If at 6 months it's still not, we might consider sending them to a pediatric oncologist or urologist. But it's just going to be surgery to bring it down. Again, not an emergency. Hypospadias is the opening underside of the penis. So don't go circumcise them. Often the foreskin is having to be used to repair that. And the most common for surgical repair for this is 6 to 12 months old. So again, avoid circumcision with these guys and transfer to the pediatric urologist. No one's going to touch them. What's the most common following finding in AKI? Acute kidney injury, volume depletion, acute kidney injury, MA volume depletion. All right, so there you go, the renal system and all the abnormalities.